Welcome to AETCM, the Emergency Medicine channel. So, shall we start?
Yes.
A 75-year-old male presents to the ER with history of fever and palpitations of 1 day duration. On our initial 10-second assessment, patient was conscious, oriented, and obeying commands. Coming to primary survey, airway was patent, no pooling of secretions, no gurgling. Coming to breathing, respiratory rate of 25 per minute, saturation of 96% in room air. Coming to circulation, the patient was initially connected to the defibrillator and which showed a narrow QRS complex tachycardia with absent P waves and irregular RR interval. At this point of time, we asked to get a 12-lead ECG. BP were recorded, 3 readings were recorded and the average came out to be 140/90 millimeters of mercury. 2 large bore IV cannulas were inserted at this point of time. Coming to disability, GCS was
What
15.
happens to BP in atrial fibrillation?
So BP recording will be fluctuating since
Why it is fluctuating?
irregular pulse or
irregular pulse. How can it reduce or increase BP? BP also depends on your stroke volume. Okay. Each stroke, each cardiac cycle, strokes are different. The percentage of strokes are different in atrial fibrillation because some beats it will be very narrow. Okay, so ventricle will not get time to dilate, okay, or get more blood. So that beat the volume will be less. So each pulse it will be different. BP will be different. Ideally, it should be continuously monitored, but unfortunately, in many centers it is not possible. That's why we are taking at least 3 readings and take an average. Okay, single reading sometimes it will be like very dangerous. Sometimes it will show very high BP. Sometimes it will show very low BP.
Coming to disability, GCS of 15/15, moving all 4 limbs, bilateral pupil equally reacting to light. Coming to exposure, temperature of 100.3 degree Fahrenheit, GRBS of 160 mg per deciliter. Injection PCM 1 gram IV stat was given at this point of time. Coming to adjuvants of primary survey, our 12-lead ECG came, which showed a narrow QRS complex tachycardia with absent P wave and irregular RR interval. We did the 6-second rule and the number of P waves in 6 seconds was 14. So the rate was 140 beats per minute.
Okay.
We took a CBC CRP point of care which showed a total count of 15,000, CRP of 30 and ABG showed potassium of pH of 7.35, PCO2 of 48, bicarb of 24, PO2 of 92%, 92, potassium of 4, creatinine of 1.3, sodium of 130, lactate of 2.3 and HB of 11.5.
What is ABG?
pH of 7.35, PCO2 of 4.
What's the interpretation?
So slightly on the alkalosis side.
7.35.
7.35 acidosis side, slightly on the acidosis side.
Bicarbonate.
Bicarbonate was 23.
PCO2 was little high, no?
48. Slightly respiratory.
He is a COPD person.
No, sir, not a COPD patient. History of smoking is there, but no COPD history is there.
Okay.
Chest X-ray portable was taken at this point of time, which showed a non-homogeneous opacity in the right lower zone of the lung. Coming to sample history.
And that is not all enough. Right lower zone of lung, there is a homogeneous opacity means what you...
Non-homogeneous opacity.
Non-homogeneous opacity. Okay. What all differential diagnosis for that?
Sir, can be either a infection, pneumonia, can be there.
If it is homogeneous opacity in the right lower zone?
Pleural effusion can be.
Pleural effusion, then?
Large consolidation.
Consolidation.
Then collapse.
Collapse. How do you differentiate collapse from consolidation in X-ray?
Tracheal shift.
That is only if it is top. If it is in the upper zone, you can make out like that. Lower zone, rib spaces and cardiac shadow will be shifted towards same side. Okay, so this one is non-homogeneous. Okay.
Coming to sample history, a 73-year-old male, known case of type 2 diabetes, hypertension, presented to the ER with history of fever and palpitation of 1 day duration. Fever was low grade, intermittent, no chills or rigor, decreases on medication. It was associated with palpitation that was intermittent, lasting for about 5 to 10 minutes. No positional diurnal variation, no changes with exertion. No history of any altered behavior, chest pain, breathlessness, syncope, edema, orthopnea, PND, slurring of speech, deviation of angle of mouth, or generalized tiredness. No history of any allergies, no history of similar episodes in the past. The patient is a chronic smoker. History of diabetes and hypertension. For diabetes, patient is taking OHAs, and for hypertension, telmisartan. Coming to general examination, no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy or pedal edema. Coming to CVS examination, JVP was normal, S1 was variable, no murmurs were present. Coming to respiratory system, minimal crepes were noted in the right axillary area. GIT was soft, non-tender and bowel sounds were present. Coming to CNS examination, GCS was 15 by 15, power 5 by 5 in all the 4 limbs. Reflexes were present, bilateral flexor plantar. Our initial diagnosis was a stable new onset AF with fast ventricular rate, which is precipitated by an infection.
Okay. So when you are talking about a rhythm abnormality with fast ventricular rate, what is the first thing you will document? You are having a patient who is having some supraventricular rhythm, okay, narrow complex, and ventricular rate is very high. What are the things you will document before treating the patient?
Stable or unstable?
Stable or unstable. What do you mean by unstable patient?
Unstable patient means the symptoms like altered mental status, signs of shock, signs of acute heart failure,
Chest pain.
ischemic chest.
So these are the important things you have to see before treating. Okay. So this patient is stable or unstable?
Stable patient.
So this patient is having narrow complex tachycardia, which is irregular, and patient is stable. So your diagnosis here will be atrial fibrillation. Reason for atrial fibrillation may be lung infection and fever. Okay, these are the 2 things we have, or he might have had a past history of coronary artery disease that we didn't get the history. Okay, how do you proceed with this patient?
So in this point, we are
What is the
suspecting
O2 level in this patient? Saturation?
saturation was maintained 95%.
Heart rate? Respiratory rate?
Respiratory slightly tachypnea. Patient was having 25 to 30.
30. So what are the first things you do in this patient?
First, we suspecting an atrial fibrillation. First, we have to rule out the reversible causes of atrial fibrillation. Present patient is having slightly anxiety. We will calm down the patient.
Okay.
And then for the initial management, the patient is having history of fever. That can cause tachycardia.
Okay.
That can lead to decreased
Give
diastole.
IV paracetamol. Okay.
mostly.
Second thing.
Second thing,
Tachypnea is very important. All supraventricular rhythm abnormalities, including atrial fibrillation, tachypnea. That means patient is having respiratory infection, and that induces some increased work of breath. That has to be controlled. Second thing. First is paracetamol. IV has to be given. You have to control the fever. Second thing, you have to give oxygen. Okay. Even when the saturation is normal, rate of breaths are very high. So that has to be controlled, and you know that there is a pneumonia is also there. So you have to start oxygen. Okay.
then we will go with rate control initially in the ER settings. We will give IV metoprolol 5 mg 5 minutes apart.
First, you have to see what are the options. What are the options you have to control the rate?
Rate control and rhythm control. In the ER settings, acute settings, we will go with initially rate control.
Rate control drugs like
Beta blockers,
beta-blockers
calcium channel blockers like verapamil
and
diltiazem.
diltiazem. The third one. First is beta-blocker, second is calcium channel blocker. Third one,
Amidron, digoxin.
digoxin. Third one is digoxin. Okay, digoxin indications are different. Fourth one is amidron. Amidron has got both the power for rate and rhythm control. So normally we select first 2 things, diltiazem or verapamil or beta blocker. Here which will be ideal drug in this case?
Beta blocker.
Beta blocker can be given, but the problem is you have to ask before giving. You have to ask history of bronchial asthma, COPD, all these things you have to ask. And if there is no other history, you can give safely beta blocker. So what happened?
We have given IV metoprolol 5 mg and we observed for 10 minutes, but the rate was still on the higher side.
Okay. So what you did?
We again repeated IV metoprolol 5 mg. Second dose was given.
Okay.
And this rate slightly decreases to, it was initially 140, 150 range, which came down to 130, 125 range.
Okay. You finished with that or gave further doses?
Yes, then we already informed the cardiologist regarding this AF. So we started the patient on amiodarone infusion.
Okay. So you give metoprolol 2 doses. Ideally, you can give one more dose. If there is no hypertension, you can give another dose. There is no issue. Then, if it is not getting controlled, then better go for amiodarone infusion. When will you give digoxin?
With heart failure.
Only if there is a heart failure, you have to give digoxin. Otherwise, we will not give that. So, amiodarone, what dose you are given?
150 mg stat dose over 10 minutes. Then we give 360 mg over the next 6 hours and 540 mg over the next 18 hours.
Okay, then what happened to the patient?
Within 24 hours, the rhythm got normalized and it was normal sinus rhythms.
Okay, what else you have to give for this patient? One is rhythm control, rate control. Rate control and rhythm control is done with these 2 drugs. Second problem is what?
Anticoagulation.
Anticoagulation. What anticoagulation you give?
We can give heparin.
Heparin. Okay. Heparin, how much you give?
1 mg per kg PD can be given.
Enoxaparin. Okay. That was given. VD was given. Okay. So basically these things has to be given. Should we continue warfarin in this patient?
That depends on the chat to VAS course.
Okay. Normally, if the AF is persisting, then you have to think about all these things. You have to continue that. Most of the time, this is a problem triggered by the hypoxemia or fever or some myocarditis produced by viral fever. We don't know what is the reason, but mostly they will settle down. Within 1 week, they will settle. If it is persisting, then you'll have to continue. Okay. What happened to the fibrillation afterwards?
It was controlled with.
Controlled. So rate was controlled. Rhythm also controlled.
Rhythm also controlled within 24 hours.
Okay. How do you treat the infection?
Infection, we started the patient on. We can either start, since the patient is coming from a community. We can start with fluoroquinolones, which has a good gram positive, gram negative, and a typical curve.
Okay. What is the age of the patient?
73.
Okay. Fluoroquinolones are an ideal choice, but when the patient become old, you have to be very careful in giving quinolones. Sometimes it can produce seizures. But it is a safe drug. You can give safely without any problem. But if you have to ask history of seizure and elderly individual, you can try to avoid this drug. Suppose you want to avoid fluoroquinolone like levofloxacin, moxifloxacin, what is the next choice?
We can give ceftriaxone.
You can give ceftriaxone. 1 gram or 2 gram IVOD can be given. What else?
We can give azithromycin for atypical coverage.
Okay.
Now we have this patient with fever with a new onset arrhythmia, no? So other than the conventional thoughts, is there anything else you need to look into?
So in the case of AF?
No, basically a new onset, fever with a new onset arrhythmia, right? So always look for other signs of myocarditis and things like that, okay? And infections which can precipitate myocarditis. So those kind of workup also needs to be done. So any situations where probably you will not consider beta blockers in new onset AF?
History of any bronchial asthma.
Other than that? If the patient has any WPW syndrome or things like that, no? So in those kind of situations, you are not going to consider metoprolol as a first choice, right? Okay.
So what happened to this patient on discharge?
They have done a echo, which was found to be normal. LALP was found to be normal.
Why echo is done in atrial fibrillation?
Certain persistent and permanent AF, if you look at the echo, there can be left atrial enlargement, chamber enlargement can be seen.
In emergency room, I am talking about ER physician.
LA clots.
Clots. For us, it is clots. But a cardiologist look everything. They want to see what is the size of LA, what is the size of LV. All these things have to be documented, and you have to see any valvular derangement. All these things has to be looked into. But for a ER physician, we are more bothered about whether there is a clot or not, especially in the LA. LA clots are very, very common in atrial fibrillation. So that has to be ruled out. If that is there, then we'll have to put on warfarin or some other oral anticoagulants. That has to be started. On discharge, when you discharge the patient, how do you follow up this patient? It is not coming under emergency medicine topic, but what do you want to follow up? So echo is done already. We can discharge the patient, but anything else to be ruled out? One of the most important cause for any arrhythmia is ischemic heart disease. Okay, and fever can be a trigger for that. Fever, somebody is having an ischemic heart disease. When you have fever or infection, that becomes a trigger for, or that can exacerbate the condition. Fever, anemia, pregnancy, so many conditions can exacerbate a heart disease. So if possible, you have to do a angiogram. At least we have to do a TMT. If the patient is able to walk, we have to do a TMT or halter, something like that. We have to follow up the patient. Okay. So starting amiodarone will control the rate and rhythm, but after sometimes patient can come back with the same problem. Okay. What are the complications of amiodarone infusion in your ER or ER-ICU?
Hypotension.
Amiodarone normal course, it can pharmacologically it can produce hypotension, but normal course we don't see any hypotension unless until patient is having a cardiac failure as such.
Hypo and hypothyroidism.
They produce acute thyrotoxicosis that can produce hyperthyroidism initially. Then patient may develop hypothyroidism. So in ICU mostly they develop hyperthyroidism. So that itself can produce sometimes tachycardia. So you have to check thyroid function test frequently. Then once you discharge the patient, when they come for follow-up, always check for a thyroid function test to see whether the patient has gone to hypothyroidism or not. Initially hyperthyroidism, then patient go to hypothyroidism. Okay, like that liver function test, liver fibrosis can occur. So many complications are there, but they all are very, very rare. Why we are not giving digoxin? Why digoxin is removed from the treatment protocol?
Yes.
It is an arrhythmogenic drug, pro-arrhythmic drug. Same time it is anti-arrhythmic. It can also produce arrhythmia. Okay, the therapeutic index is very narrow. Okay, what is drug holiday? What do you mean by drug holiday? Tell some examples for drug holidays. One is digoxin. 5 days only you give. 5 days in a week. 2 days you give holiday. Why you give holiday?
Toxicity.
It is not toxicity. Huh? Same like that you give what is that?
Lithium.
Sorbitrate. How do you give sorbitrate? Sorbitrate we give for all patients, no? Ischemic heart disease. It's commonly used drug. NTG infusion we give in ICU. Huh? How long you continue NTG infusion? 24 to 48, maximum 48 to 24 hours you have to stop it. Why you want to stop it? What is tachyphylaxis? What is that?
Tolerance to.
What is that? All these drugs go and attach to some receptors. Okay. So when you're treating, this drug will go and attach to some receptor and act there. Okay. But after some times, all these receptors are fully loaded with drug. There is no more attachment. So new drug cannot act. So you give some time to relax that attachment, and that attachment will go. New drug can be given. That is tachyphylaxis. So all these drugs sometimes we'll have to give drug holiday. Okay. Warfarin, how do you start? So that is about digoxin. You have to give only 5/7. And if the patient is having renal failure, you have to make it half dose or quarter dose depending on the creatinine clearance. Warfarin. How do you start warfarin? So this patient, suppose you are starting warfarin. How do you start? Now newer drugs are there that doesn't need any monitoring, but these drugs are very costly. So routinely everyone start warfarin only. How do you start warfarin? Suppose you want to start warfarin along with your heparin in this patient. You start warfarin, heparin together, or
Initially heparin, then we bridge.
that is the most important mistake everyone do. Initially heparin and after that warfarin.
Start warfarin on lower dose initially, then
How do you start? If you want to start warfarin in any patient, like suppose you want to start warfarin here, you start heparin. Along with heparin, you have to start warfarin. Why it is like that? It takes time to act. Okay. High dose warfarin with heparin and titrate down the dose of warfarin. That is an usual protocol. But many doctors like this, you told, first start heparin, then complete heparin, then start warfarin. And warfarin will take at least 7 days to act. So that 7 days there is no protection. So always try to start heparin, warfarin together and continue that for heparin for 7 days. Discontinue heparin. By the time warfarin will have its peak action. Okay. Ideally warfarin has to be started somewhere around dose of 10 milligram, then taper down. But many doctors start in a lower dose and going they increase the dose, hike up the dose. There is also okay practical, but ideal situation you have to start higher dose and taper down. Okay. What happened to this patient? Discharged.
Yes.
Okay. Thank you.